Hey everybody, welcome, and let's go ahead and get started. I want to welcome you all to our 7th Learning Collaborative for the Patient-Centered Medical Home. I'm Dennis Quo. I am the Vice President of the chapter. I want to welcome everyone. We've got a treat for us. We've got our guest speakers who will be discussing share implementation and with us. And depending on the amount of time we have, I've got some additional slides on just the concept of profound knowledge, just to stimulate some thought and discussion about making changes within practices. Kristen, next slide. Just a few teleconference reminders. Please mute the phone when you are not speaking, but please do not put your phone on hold. As many of you have heard, if you put your phone on hold, we may get your hold music, and it's distracting. So just please be mindful of that. Next slide, please. And our objectives today is, first we're going to have Amy Ollinghouse give us an AAP update. Our second objective is to hear some information on share with our guest speaker, Jan Bartlett. We're very happy to have her. Third objective, depending on time, I will discuss a little bit about the concept of profound knowledge, just an interesting concept to share. Then we will go through just upcoming events and reminders, and we'll close with a review of the requirements and questions. Next slide, please. Support from last year was provided by the Fluent View Foundation. Current support is provided by Arkansas Medicaid. Our subcontract from the chapter is active. We're happy to partner with Arkansas Medicaid, and we think it'll also help us bring more activities to you all for successful implementation. Next slide, please. And this is your AAP leadership. If anybody else is on the call and wants to introduce themselves, please go ahead. Kristen, I know you're on. Is Amy, are you on? Kristen, you're on, right?
I'm on, and I know Dr. Rogers has a meeting today, so he is definitely not on.
Okay. Okay. Do you know if Amy's definitely coming?
I'm here.
Oh, you are? Okay.
Yeah.
Okay. I think you're next on the agenda. That's why I asked.
Oh, okay. I wouldn't miss it for any.
Okay. Next slide, please. Okay. Kristen, do you want to take roll call, or can we move on in the interest of time?
Let's move on, because I can go back and check the box and see who's on.
Okay. Next slide, please. Okay. So we are now in past the 6th month, and I'm assuming at this point that folks who had any feedback from their 6-month metrics that require them to provide a quality improvement report because of some noted deficiency on their reporting have returned the QIP. If there are any questions, or if there's any feedback that you'd like on the quality improvement reports that you might have had to submit to AFMC, please feel free to let us know, and we can work through that with you. We've had a lot of conversations with both AFMC and Qualis Health about the 6-month metrics, particularly about the metric regarding same-day appointment review and same-day appointment scheduling and review. Some of you may have also been on the webinar that AFMC presented on the same-day appointment metric, and we're happy to clarify any questions that you may have on that. So we are now getting into month 12, and from the work group calls that we've had, I have not yet seen anything new about the 12-month metrics reporting. That is, of course, a little bit of ways away, but we're happy to pass on information about them as the 12-month metrics get closer. One of which, of course, is to join SHARE to get inpatient discharge information from hospitals, and that's why we've asked Ms. Bartlett to present for us today. Next slide, Kristen. So I've always, I'm one of the ongoing mantras that we'll keep presenting is how do you know that you're making changes in how care is delivered? And I'd like us to continually think about that, particularly as we get into learning collaboratives and discussions, because we really want this to impact the way care is delivered and see it changes from how our patients and families report to us how care is being delivered. We will always endeavor to make sure that we let folks know where we think this is all heading as well. You know, we think that as time goes on, we're going to start seeing more and more focus on the high priority beneficiaries and children with special health care needs and population management. So that means that we'll pay even more attention to the utility of care plans and adoption of electronic care plans. And as we know, that'll start getting into the metrics for after month 12. But I do want us to always ask ourselves, how will we know and how will we measure that we're making changes in how care is delivered? Next slide, Kristen. Okay, Amy, it's yours. Amy?
Yes, I'm on.
Okay.
Sorry.
You ready?
Took a sec. Yeah.
No problem.
To unmute. So my chapter update would be that Medicaid, I believe, has decided and named a new director of Medicaid. I guess I should say DHS has done that. I don't believe that that has been officially announced, but I also haven't heard any word that the information is embargoed for a period of time. So,
Amy, I thought I saw a press release on it, or at least it appeared in the media. So I think
okay.
it's easy. I think we can say who it is.
Okay, so John Seelig named Don Zekas, who is the interim director of Medicaid, to the permanent position a few days ago. So she will be leading the Division of Medical Services moving forward. I don't know how many of you guys are familiar with Marilyn Strickland, but she has been a long-time employee of the Division of Medical Services, and she has, has vast institutional knowledge and working and understands the workings of the program, and she has submitted her resignation for, I believe, sometime early in 2015. I can't recall the exact date. So with that said, I think that, we're seeing lots of rapid changes in leadership at Medicaid, but we're hopeful that, as we move forward, that they keep an emphasis on PCMH. They continue to work with us, and that, it all benefits you guys, the providers, and ultimately the kids in our state. AF&C, I don't really have a specific update for them. And Qualis, I know, has responded to the RFQ that was released to provide second-year practice transformation.
Yeah, we have a WebEx in here. But I don't hear her.
So as far as, those would be my only updates at this point, I believe. If anybody has any questions, I'd be happy to answer them.
Okay. Amy, thanks. And Dawn, her last name is it Steele? Stell?
It's Zekas.
It was Zekas. It's been changed. Her name was her name changed about a year ago.
Okay.
Anyway,
I don't know her as anything
Dawn
but
Steele she was Director of Healthcare Innovation at DHS, which means that she was basically overseeing a huge part of the Payment Improvement Initiative. So, I think that this, there's a lot of changeover that we're seeing, certainly at DHS, but I think that this move from of naming her as a director is a good one particularly for continuity for all the advances and all of the innovations that Medicaid has put forth. So, I think we want to welcome Dawn to the new position, and we'll be following up with her at the chapter level to make sure that there's that ongoing communication and to also hear her ideas about her views for Medicaid going forward. But since she was essentially a huge part of the Payment Improvement Initiative, there should be a fair amount of continuity in where Arkansas Medicaid is heading. So I think that's a good thing. Any questions or other comments? Okay, next slide. Kristen, next slide, please.
Oh,
no problem.
Sorry. I pushed it over to the next slide. Can you not see the next slide?
There it is.
It's introducing
Okay.
Jan Bartlett.
Okay, that's up on my screen now. So, Jan,
Yes.
over to you. Thanks for and thanks for taking your time out of your busy day to be with us today. Appreciate it.
Well, thank you. We appreciate the opportunity to talk to you. I'm joined today by Deborah Lombas, who is our onboarding director for SHARE, and Justin Valines, who's just joined us as our PCMH policy integrator. So we are glad to give you an overview today of what SHARE is and how far we've come in the last several months. Next slide, please. So SHARE is a statewide health information exchange, and today we want to visit with you about how not only we can help the clinics that are enrolled in the Patient-Centered Medical Home Initiative, but also how we can help you provide quality care and improve efficiencies in your practice. Next slide, please. Next slide, please. Okay, next slide, please. So we started.
There's a little delay between when I switch it and when it shows up. Sorry about that.
Okay, thank you. Well, we started SHARE in 2009 with ARA funds under an executive order from Governor Beebe. And in 2011, SHARE had its enabling legislation passed. So from that time forward, we've worked to build an infrastructure for providers, labs, and pharmacies. Next slide, please. So you can see this is a diagram that shows you that without SHARE, information is passed directly from one provider to the other. There's no integrated source. But if you look on the right side, you can see that through SHARE, you're able to access that information through one source in real time. Next slide, please. So there's three ways to connect to SHARE. You can do it through secure messaging, through the virtual health records, or through the health information exchange. And I'm going to give Deborah Lombas an opportunity now to tell us a little bit about each of those different kinds of methodologies. Deborah?
Hello, and thank you. As Jan said, there are three ways that you can connect to SHARE. Our first solution is secure messaging, and it really is just a simple point-to-point encrypted email system. It follows all of the direct protocols, so it is HIPAA and HITECH compliant. Secondly, we have what we call our virtual health record. And what the virtual health record is a secure online portal where your users can actually go in, log into the secure website, and view the patient data that is available on your patients and is being pushed from other healthcare entities. So, for example, if you have Children's Hospital pushing data into the HIE you can go in and view that data in a consolidated format on the web. There's no EMR needed for that solution, and we also have the ability to push event notifications into what we call our clinical inbox within the virtual health record, so that you can also know when your patient has been admitted or discharged from the hospital. The Health Information Exchange is a more integrated solution, and the reason most practices choose to integrate their EMR system with SHARE's Health Information Exchange is because it keeps the workflow seamless. If your vendor is capable, we can connect or integrate with your vendor to actually push data from the hospitals and other healthcare providers about your patients. We can push that into your electronic medical record so that you don't have that separate portal with a separate user ID and password to go and look for the information. So it does make it much more seamless and provides that pertinent health information at the point of care when it's needed.
Thanks, Deborah. Next slide, please. All right, so you can see, given Deborah's explanation, that without SHARE, you're really dependent upon that person, either the patient, to get their record in. And I hear stories about patients that arrive at the emergency room with the medical record strapped to the gurney. Or you can look and see that with SHARE, that data can even arrive before the patient gets there. It's in real time, and you can see that that would provide a great benefit. Next slide, please. There are all sorts of different kinds of information that can be exchanged through SHARE, and this is a slide that shows you that. Through the HL7 messages or the continuity of care documents, you can see here that SHARE is able to provide not only the lab results, the radiology testing, the medication histories, the problem lists. You can use this for referrals, allergies. The next slide, please. And I guess especially important for today as we talk about the patient-centered medical home is, as Deborah mentioned, the reason that SHARE has been made a requirement is because these alerts, or sometimes called event notifications, can be sent from the hospital to the clinic so that you know when has that patient been admitted to the emergency room, when have they been discharged, when has the admit been canceled. And that information, as Deborah explained earlier, there's those 3 different ways to receive information through SHARE. So not only can you receive the alert through the fully integrated solution, but also if your clinic is accessing SHARE through the virtual health records, you're able to access that messaging through the inbox, through the clinical inbox. So we think that this will provide not only the opportunity to lower costs, but also just to stay on top of where your patient is when they're admitted. Next slide, please. And of course, along with all this comes the ability to help you meet your meaningful use criteria. This is a slide that lays out some of the different ways that SHARE can facilitate that. Next slide, please. We want to give you an update now of where we are in the process. We have really made some great strides, especially since the beginning of the year. Next slide, please. Our total right now is 221 practices, and that is composed of 39 hospitals, 12 which are live, and 196 practices. So you see there on the map where the red represents the hospital and the blue is the clinics. Next slide, please. So here's a list. So when we say that a hospital is connected, that means they're actually getting a live feed. If a practice is connected, that's a live feed. So this is a list of those. This is also available on our website. We have a directory that you're able to access, and we'll give you the link to that at the end of this presentation. Next slide, please. Now, some of the hospitals that you see here in practices, they're in the process of connecting. And what that means, they may be in testing. The initial process for joining SHARE is to sign a participation agreement. And all that, really what that sets out is the agreement to comply with the privacy and security standards. But some of these, at a minimum, these hospitals and practices have signed those agreements, and they are somewhere in the process of going live. And you can see Arkansas Children's Hospital leads this list, and we're very excited about them coming on board, and we anticipate, let's see, Deborah, when is it September 15th? When is their go-live date? Yeah, their go-live date is September 15th, so we are excited about that. Next slide, please. So all in all, we've got over 685,000 discrete clinical records in SHARE. So we are really proud of the fact that we're making a lot of progress. Next slide, please. Okay, next slide, please. So one of the things we've been able to do to bring the cost down for practices is to negotiate statewide contracts. And that's really resulted in not only in reducing or waiving the one-time vendor interface fees for connecting to SHARE, but it's also shortened the implementation time frame. This little label that you see there, SHARE Connected EHR System, that logo is something that we're using on an application called DocWrite, which AFMC is using. And as I understand it, if a practice is shopping for an EMR, they can go out to DocWrite, and if you see this label, it indicates that a statewide contract has been negotiated with SHARE. Next slide, please. So here are some of those that we have this connection with. And overall, this means that on average, we've been able to save the practices approximately $10,000 in most of these contracts. Next slide, please. And these are some of the other vendors that we are in discussions with. Do you want to add anything here, Deborah? Okay, next slide, please. And let me just say this, if you don't see your EMR vendor there and would like for us to initiate discussions, please just give us a call. So this slide shows you how much we've been able to save the practices joining SHARE with each of these different vendors. Next slide, please. So here's some basic pricing for our practices. You can see that unlimited VHR and secure messaging is $50 a month. For the interface systems, you've got, when it says one VHR primary clinical user, as you may know, we are an opt-out state, and what that means is that patients their information is included in SHARE unless they opt out at the point of care. The information then is, if you have opted out, is only available under an emergency circumstance, and a primary clinical role is able to break the glass. So that's the import of that clinical role there. If you want unlimited primary clinical users, the cost is $75 a month. And then you see below on the bottom half of that chart, the vendor fees, those vary. There are one-time fees and monthly or annual fees, and those are all dependent upon the vendor. Next slide, please. I'm going to turn the program over to Justin Belines now, who's going to talk to you specifically about patient-centered medical homes.
Hi, thank you for having us today. Again, my name is Justin Belines, and I'm going to briefly touch down on the expansion of PCMH within Medicaid. For this slide, next slide. New in 2014, Arkansas is now requiring at the end of this year for practices that are part of the PCMH Medicaid program to be associated with SHARE and to have that implemented within your practice. So that way that you're able to access that inpatient, that admission, that transfer H&P discharge information, and receive that from affiliated hospitals that are associated or are connected with SHARE. And you can see that mandate in the Arkansas Medicaid PCMH Handbook 240, Metrics and Accountability for the Payment Initiative, if you want to reference. So you can see that connectability within the PCMH, that model of care orchestrates that care across all venues, uses the information to link the caregivers within your practice and across the community, and also really provides that preventive, acute, and chronic care that our patients need so badly across, not just our urban areas here, but across the state and the rural areas. And you're able to really connect that through SHARE and see that in a seamless manner. Next slide. So SHARE for PCMH, and you can see this. One of the biggest components that is what I'm excited about and for our state, and that you will have that connectability from SHARE to be able to see what patients that you have in your within your clinic that are admitted to a hospital or that are discharged from a hospital, and see that in real time. That's going to be able to allow you to do that follow-up, that you're going to be able to get those patients back in your clinic and essentially continue to keep them out of the ED. So participating SHARE providers, you receive that instant notification, and so you're able to then start, addressing the issues at hand. This allows you to really follow up and offer that care management solution, which is the intricate part of the PCMH model of care. Next slide. So PCMH practices will be required to participate in SHARE. This will allow you to obtain those discharge, that data from that hospital, whether it's UAMS or Children's or any community or critical access hospitals that's currently enrolled in SHARE. That having that EMR integration is not required until 2015. OHID is working with Qualis and other vendors, this is just an example, to ensure practices are properly connected to SHARE for the compliance of PCMH. So really allowing you to continue that funding mechanism that's in place within our state. And like Jan talked about, the secure messaging, that HIS to HIS, and you'll see that in the next slide, which is the health information service provider, going from that service provider to another service provider. Secure messaging, that sender goes from the HIS, which is SHARE, that master provider index, to the receiver end. So this really facilitates that secure messaging. It also facilitates that push or that transmission of the health information exchange of that data. It also utilizes that direct standard that's in place and the security protocols that we have in place to really put that in a seamless manner. And then have that direct trust system, that candidate status, full accreditation, and that trust bundle. Next slide. So secure messaging, just going in detail, system with expanded features. So it has things such as functions like a traditional email, provides notifications to a third-party system, cloud-based. It gives you that alerts that will alert you. Say you have a patient that had labs at another institution or had, a recent hospitalization, et cetera. Next slide. So again, HIS, the Health Information Service Provider Services Model. This is kind of broken down so you can understand it in a more logical manner. Can your system connect to SHARE for secure messaging? And these are different scenarios that you can take in place. You can have SHARE as your HIS, as that provider, which really, if you sign on to SHARE, you have secure messaging, then the webmail, that direct trust model, which enables secure PHI emails between SHARE and SHARE-connected users. Then you have that HIS to HIS. If you're using a vendor such as ShareScripts or a DataMotion, it allows that messaging between different HIS system, so that health information service provider, and it can then communicate within Share. Or you can have a XDR to SMTP, and all that really is talking about is the attachment. Really understanding that, and that's from, using a particular vendor such as Meditech, in which Children's Hospital is using, that enables that attachment to talk to another attachment and go over that protocol. Then you can communicate that within Share. Or you can have such a thing as XDR to XDR, such as using Epic to enable that HIS whenever you're connecting. And really, when you're talking about this mechanism, that really is a vendor question, depending upon that communication that you have with your vendor, and you're able to receive those in such a manner. So whenever you're going out and you're talking to your vendor and about these, ask those type of questions, because they're the ones that's going to really be able to vet those questions for you. So Share is a vendor agnostic. We work with anyone who can meet our tech and contract specifications. And that's why, as the slides previous, there's ongoing talks and communication to really make this as streamless as as possible for all parties that's involved. Next slide.
Okay, there we go.
Okay, sorry. Immunization reporting, and this is a really key part for our state. One of the key parts of the patient-centered medical home with Medicaid and Meaningful Use is to really have that streamless process of submitting your immunizations and connecting with the ADH. So automate immunization reporting through Share is a capability. Share has built an interface with the Arkansas Department of Health, which is great for our state. You're able to send that immunizations data directly to ADH through Share once you're connected. It's a simple workflow for reducing duplicate data entry. A lot of practices right now in your workflow, you're having to put it in two different, your nurse or whomever put that immunizations in. You have to log on to ADH and put that in at one time, and then for your practice to be able to see it. So you're eliminating that time that it's taking you there, that you can put that effort into other parts of your clinic. So the immunization registry is live with ADH. ELR and syndromic surveillance reporting is available next. And you're going to see that's going to be one of the key mechanisms whenever you're going after the Meaningful Use dollars and within the Medicaid expansion. So this is a no additional cost to Share participants. So this is going to be included whenever you sign up or continue that process. Next, please. So workflow, this is just illustrating workflow without an interface. Everyone sees the different things from a patient intake. You have a phone call, you're having a fax, you're having to look at email, you're having to make another phone call, etc., trying to really gather all that medical information, meds, do a medication reconciliation, immunizations, etc. You're examining that patient, and then you're trying to document that, and duplicate efforts are taking place. Next slide. So workflow with an interface. So you can see that review of the medical history, boom, you have that patient intake. You're able to look at labs, immunizations, medications from the Health Information Exchange within the EMR patient record. Then, as you as the doc are able to really examine that patient, your nurses are able to administer that immunization, and then your staff is to document it within that EMR, which if you're connected to Share, others are able to see that information. You're able to streamline your documentation, such as your immunizations, to ADH. Next slide. So this is how you join Share, and I'm going to turn it back over to Jan, and she's going to go over the details with that.
Next slide, please. Okay, so here you see our website and our direct call-in number. And I believe if you want to call in and ask directly for Deborah, she will be able to get you connected to the right people. And I'll open it up for questions at this point. Any questions?
Hey, this is Dennis Quo, and I've got a question. First, thank you so much again for coming and presenting all this great information for us. My question, but first, I'm speaking on behalf of not only the AAP chapter, but I'm also a provider at Arkansas Children's Hospital, and so I'm not directly involved with the purchasing of share for Children's Hospital, and I've only had some discussions with folks here at Children's. I've heard about some of this. I've heard about the adoption for Children's of share, and I know that many folks on the call here are interested in knowing exactly where Children's Hospital stands. My question is that you had mentioned earlier in the presentation that there's 3 parts of share, which is the secure messaging, the virtual health record, and a health information exchange. And I really have a 2-part question to clarify for us as a group. The first is that I understand that you can purchase them separately. Is that is the case from your standpoint? Because I didn't see that in your pricing. But what I was informed was that you can purchase it separately. And the follow-up question for there, for us to understand, is.
So let me just, if I can, I'll take a stab at that, and then I'm gonna make sure that none of my other team wants to supplement what I say.
Sure.
When you sign the participation agreement with Share, you have a menu of options.
Right.
You can decide to take a tiered approach to connecting with Share. For example, you might want to start out with secure messaging, and then after a time, because your vendor has some issues, you might then want to go on over to a full integration, and that's an option for you. Each of the different functionalities is priced separately. So using the scenario I just painted, you would pay $50 a month for your clinic to receive the secure messaging. Then and let's say you wanted the VHR, which that's just the portal, you would pay, if you wanted unlimited professionals to be able to break the glass, that would be $75 a month. Then if you wanted to go to full integration, they're all priced about the same. So go ahead, Deborah.
Well, I was just going to say, though, for $50 a month, you get access to the virtual health record, and you also get unlimited secure messaging. If you do not want one of those solutions, let's say you wanted secure messaging only, that pricing is different, and we did not identify that pricing on the slide today. It's based on the number of users that you would have for secure messaging. But really the bang for your buck is to, especially if you don't want to disrupt your workflow, is to integrate with the HIE. And so for $50 a month, you get integration to the HIE where you can consume data within your EMR. You also get unlimited virtual health record access for secondary clinical users, and you get that one primary clinical user role. You also get unlimited secure messaging. So you actually get all of the solutions for $50 a month.
But I do want to reiterate, because of the different tensions that are out there with connection for PCMH, if for some reason your vendor wasn't up and going and you needed the smaller solution that's available, does that answer your question?
That does. So I have a follow-up question, and I'll ask this partly as a hospital, partly on behalf of a hospital setting, and partly so that we can enter the discussions with our hospitals, since Children's Hospital is only one of many different players. What are the options that are available to hospitals, and what do we need to be looking for when we discuss with our hospitals what they have adopted?
Okay, again, I'm going to start, and if Deborah wants to add in. I think one thing we really want to make clear here, and a lot of the reason you saw all of that information around the HIS, Health Information Service Providers, is the hospitals have the option to go with the secure messaging where the alert would travel on the CCD through the HIS. you have that option, and that is priced by the census. That is based upon the number of patients that the hospital has beds for. Or the hospital can go with the full integration. So there's that, again, a tiered approach as well for the hospitals. Deborah, do you want to supplement?
No, I think that's good.
Okay. So does that help you, Dr. Crow? Do you does that make
I do, but I think the follow-up question is that if the hospital, does the hospital have to go beyond secure message? The hospital has to does the hospital have to do the full package in order for practices to be able to participate or be able to take full advantage of the HIE functions?
Okay, now in order to take advantage of immunization or any of those other things, you're going to have the full integration. But simply to help the clinics meet PCMH, the HIS solution is there.
And if I may, Jen, whenever we go back and we're talking about meaningful use, if your practice is on stage 2, it is a requirement for you to receive all that funding on, say, the core objective 16, which is that capability to submit electronic data to an immunization registry. And so our immunization registry is 288. So that is one of the core and not a menu. So that is an area that you have to meet. If you're at stage 1 on that menu measure 9, which is a menu, so you have an option, but on that you have capability to submit data to immunization registries or immunization information systems. So depending where you are on the meaningful use, I guess you want to really make sure that you really look at the whole picture, not just that your clinic is part of the PCMH Medicaid, but for the funding mechanism that's behind it for getting federal dollars under the meaningful use, you want to make sure that you really are getting that bang for your buck at the beginning. So then it really aligns with all national and state initiatives that's happening.
Anything else? Any other questions?
Any other questions from folks?
Yeah, Dennis, this is Chris Schlitterman at Pediatric Partners in Fort Smith. Our clinic is very interested in the immunization registry, the communication with the immunization registry. Does that information just flow one way? Does it just go into the registry, or will old shot records be imported into our, the other way, going into our EHR?
Well, at this point, we've got a state law that only allows that information to go into the immunization registry. Any other questions? Hello?
Folks, any last questions before we move on?
We have a question for you.
Okay.
Go ahead.
If we are part of SHARE and we're going to be getting all of these notifications of admissions, discharges, and things, will we also still be getting all of the faxes that include all of the same duplicate information?
Hopefully this will replace that. That's the goal, is to improve those efficiencies by eliminating the need for all those faxes at a lower cost.
Okay.
And too, whenever you see the change in workflow from a hospital setting and changing toward this model of care as well, that will, I guess, really with working with your community hospitals, working with that workflow and whoever sends that, really will eliminate all of those different mechanisms in place and really streamline that process for your clinic.
Okay. Anything else? Well, let me just say we appreciate so much the opportunity to talk to you today. And if some questions pop up, feel free to give us a call or email us.
If it's a new double, it'll push through here, and they'll have supposedly who has it. I don't know if that's
anything else? Well, Dr. Quo and Amy, thank you so much.
Okay, thank you so much. I really appreciate your time today and all the great information. And folks, if there are follow-up questions, feel free to send to us directly as well. We can hook back with the folks on the call today. So thank you again. Okay. Kristen, next slide, please. I'm going to take a few minutes and just go through something called profound knowledge, which is we've talked about PDSA cycles. I know that those of you who were at the Qualis session, I know that there was more discussion about PDSA cycles. I'm going to take it to another level and discuss something called profound knowledge. And this is a concept that we could spend a lot of time on. I just wanted to give you a little bit of a taste of what comes next. Once you really start understanding how to do PDSA cycles, the next step is to really understand what kind of understanding and knowledge you need about a test concept in order to make some appropriate changes. So the concept is profound knowledge. It asks the question, what kind of knowledge allows us to test, develop, test, and implement changes that result in improvement? It's a guideline for us to really think about how do we think through a problem and come up with possible interventions. Next slide, Kristen, please. So the concept of profound knowledge is interesting and relevant and important because it enables you to understand where to examine the changes in practice delivery. And you actually really need to develop the 4 different components of knowledge. You need to look at your practice systems, you need to look at variations, you need to look at knowledge, and you need to look at psychology. Next slide, Kristen. So let's go ahead and examine that a little bit more. So the person who developed the concept of profound knowledge was W.E. Deming, and he's considered a real leader or a master in the world of quality improvement. So Deming's theory looks at the knowledge for profound knowledge is really a way to frame your understanding of a problem to lead a transformation. So let's go through these 4 parts in a little bit more detail. The first is that in order to affect change, you need to have appreciation for a system. That means that your system or your healthcare system, the way you deliver healthcare, is really a network of interdependent components with a common aim. So your common aim as a healthcare practice is to deliver good healthcare for children, but you've got a lot of different components that works as a system. The second part of profound knowledge, understanding a problem, is that you need to understand that there is variation. Variation from different providers, variation in supply, variation in the patients who come in, and you need to understand which one of your delivery processes are stable, and you need to know which ones are not stable. Stable meaning that you can predict what's going to happen, and unstable meaning you have no idea what's going to happen that day. The third is theory of knowledge. And theory of knowledge means that you learn about something by testing and deducing and inducing and testing again. And the theory of knowledge means that you have to predict what you think is going to happen if you try something new, and then you anticipate what will happen if certain actions are taken. And that is exactly where your PDSA cycles come in, because your PDSA cycles are used to test a hypothesis, learn from it, and then try something new. Your 4th part of profound knowledge is that you have to address the psychologies of individual society of change. And put simply, that means you address the human side of change. You have to look at the human aspect of your healthcare system. You know, understand different personalities, understand different areas of knowledge that folks have, and the different perspectives that people have. You know, as many of my quality improvement teachers have said that 80% of changing practices or 80% of quality improvement is really the human side of it. So we want to make sure we don't underestimate the psychology of individuals in society and change. Next slide. W.E. Deming's basic message is that the cause of inefficiency and poor quality is the system. It's not the employees. And it's the management's responsibility to correct the system in order to achieve desired results. So the only way you really are going to understand a system is that you have to develop profound knowledge about your system in the first place. Next slide, Kristen. So this is a nice summary slide. So in order to achieve quality improvement in learning, you've got to address these 4 aspects. For systems, you need to understand your systems. For people, you need to remove their barriers. So that means that you need to understand the psychology of people and what makes people tick and what motivates them, and then you've got to remove their barriers to success. At the lower right-hand corner, you've got variation. And variation also means that you're able to predict what happens, and you need to be able to reduce variation in how you deliver your process. And then you need to be able to measure that, and that comes down to statistics. The lower left-hand corner, you've got knowledge, and knowledge is increased by testing and PDSA cycles, and then you look and see how successful you were, and then you reflect on what worked, and then you start it again, and you plan to improve. Next slide, Kristen. So let's take an example of how you used profound knowledge to address the problem. And I think the reason I've thought about this recently is because one of our personal experiences at Children's is that our 3 to 6 year visit metric with so we're required for shared savings to have 3 to 6 year olds have to have at least one wellness visit in the prior 12 months. The target is 67%. We were right on around that target, or slightly below. I'm aware that a number of folks on the call are either at or not quite meeting that metric either. So let's say your practice is at 60%. And we know it's an issue. We know a lot of our kids may not come in for various reasons, and we've already tried reminder phone calls, reminder postcards, etc., and we just kind of keep going around and around, and things aren't changing. So what I posit is that you think about using the system of profound knowledge to think through the components of what you need to address. Next slide. So here are examples of how you think about a problem using the system of profound knowledge. So under systems, you have to think about what are the components of care that go into well-child visits. So what's your waiting time for appointments? You know, what are the hours convenient for parents who come to your visits? So if your waiting time is 2 or 3 months, or if you don't have any time after school or after work that's convenient to parents, that may affect your show rate, no matter how many reminder cards you send out. Variation. Here's an example of variation. Do all providers follow the same routine to schedule appointments? Do folks remember to write down a scheduled appointment the next time? Is there variation in how your providers schedule appointments? Knowledge. Knowledge means that you're going to test something new and see what happens. For example, do we know what happens if you try a different kind of reminder system? What happens if you use text messaging instead? Let's say that's an option that's available to you. What can you learn from trying something, and then what can you try next? The psychology is, what is the barriers, what is the buy-in for changing something, and what are the barriers for staff to try something new? Are staff motivated to address this issue? Are staff interested in addressing this issue? Are staff excited about this issue? Do staff despondent or frustrated about the issue? We have to develop, PDSA cycles to really address the psychology and the human side of change. Next slide. Okay. Any questions on profound knowledge? I'm going to go through that again at learning sessions. We can do some exercises. We can discuss about, use that to brainstorm about ideas of how we want to affect change. Again, it's all about how do we make changes in our practices to the point where we can see a change in how families receive care. Any questions? Thoughts? Okay. Okay, Kristen, I'm going to turn it over to you for the remainder.
Thank you, Dr. Kuo. And I just wanted to remind everyone, the upcoming enrollment is September 1st through November 17th of this year, and all of the PCMH practices are required to re-enroll. And they've made it pretty easy. They have a new form that we can go over either during the learning session or our next webinar to re-enroll. And they just really would like to make sure that all of your participating physician information is up to date. If you have new contact leads, it's important that you update this on your new re-enrollment forms that will be submitted to HP. Are there any questions about this? Okay, great. Some upcoming events. We'll continue with our monthly webinars every fourth Tuesday at 12:15. We have 2 upcoming in-person learning sessions, October 17th and March 24th of 2015. And I have a few slides for our October learning session and pediatric forum. The learning session Friday, October 17th, will be in Children's Hall at the ACH campus, and immediately following there will be AAP annual business meeting and a complimentary reception to provide an opportunity for networking. And we invite everyone to stay for Saturday's forum. We will provide a hotel for those who come to the learning session and stay for the forum. It's first come, first served, because I don't have a huge block of hotel rooms. I think we've blocked about 12. And there's going to be a lot of new, exciting learning opportunities and events, such as the ability to become certified to apply and bill for the new fluoride varnish procedure. And please contact me to let me know if you need help getting a hotel, or that you're going to come, or if you can't make it. And we're going to be sending out the flyers about this, but the Pediatric Forum is presenting a focus on oral health Saturday, October 18th at ACH in Chairman's Hall from 7:30 a.m. is check-in, and it goes until noon. And it's free for chapter members, and other healthcare professionals can attend for $25, and you can just email Amy for more information. And we know it's the day of a Razorback game, and we promise to get you out there in plenty of time to see the game. If you spend a few short hours with us at the forum, you will receive approved fluoride varnish application certification and information on billing for this service, a few hours of CME credit, an update on the latest AAP oral health recommendations, and we will wanted you to know that our Arkansas Medicaid is now reimbursing primary care physicians for fluoride varnish application, and you can get this approved training at our forum and learn about the billing codes and make sure you're up to date on the latest oral health recommendations. So please contact me, and I can also get you hooked up with Amy. We'd love to have you at the learning session and at the forum. There's a lot of great things to be able to do at these two things. So thank you, and I'll turn it right. Does anyone have questions about that?
Yeah, folks, there's the payments and the payment changes and the recommendations from the AAP about using fluoride, fluoridated toothpaste, for example, is the statement that came out this week from the AAP makes it very clear that fluoride toothpaste is actually recommended all the way down to when the first tooth erupts. So that is actually fairly consistent with prior American Dental Association recommendations, but it is something that we need to be reinforcing. And it's great actually for the state and for us that all of this is coming together at once. So, you know, we really look forward to seeing as many folks as possible for the learning session on that Friday, and then spilling over into the oral health training and discussions on Saturday. Are there any questions? It's about 1:15, so I think we'll go ahead and end. Questions, comments, last thoughts? Okay, well, we look forward to hearing from you. Kristen will be in touch with all of you. And the last thing here is make sure that you do keep an organized notebook of your progress for any practice quality audits, and we will pass on any additional details that we hear. So it's 1:15. Have a great day, everybody, and thanks for your time, and we'll talk to you soon.